very much. So yeah, I'm going to take your minds out of patients' bowels just for 20 minutes and start to think about how we can support patients' decision-making, and specifically around the decision to have a gastrostomy tube placed. So our home enteral feeding team, about 8 years ago or so, just anecdotally from speaking to patients, we felt that they weren't necessarily being given all the information that they needed to prepare them for being on home enteral feeding. So we weren't necessarily worrying about their decision nor quality or anything like that at that point. We just felt that patients could be better prepared and by being given a bit more information prior to making the decision in the first place. But then, since we've been doing this, we've evolved a way of doing it, and we've concentrated a little bit more on what we do. So really thinking about what we're saying and when we're saying it, and trying to come up with a method of supporting people to make this really difficult decision, really. The qualitative research that's out there sort of supports this. So when you look at some of the qualitative interviews of patients on enteral feeding, when they reflect back on the decision, often they feel that they weren't given all the information they need, the important things that were important to them. So things like practical things about where they're going to put the feed, important things around whether they could withdraw the feeding at some point if it was no longer meeting their needs. And then you do also see quotes like this, and for me, this tells me that the patient wasn't really involved in the decision-making process, that they maybe felt that they were an external agent, that decisions were being made for them, or they were being taken down one alleyway. And for me, this means this is going against what is commonly accepted as best practice, is shared decision-making, so where we make the decision collaboratively with patients. And I think with regards to the decision for gastrostomy placement, it's really important that we follow this process, and there's lots of value in doing that. So what I'm hoping to do for the next 18 minutes or so is try and map on the principles of shared decision-making onto the decision to have a gastrostomy tube placed, and how, using those principles, we can best support patients to make a decision that's most important for them based on what's important to them, not what we think is important for them. So there is a lot of literature about shared decision-making. This was coined decades ago, and it had been called various things. But there are certain things that turn up in the definitions and principles that maybe we should be adhering to really, really employ what is shared decision-making in involving patients in the decision. So the key things that you see, not surprisingly, are the word sharing. And that comes from two parts. So one is we're sharing the decision-making process with the patient. We're inviting them in. It's a level playing field, and we're going to make that decision together. But also you're sharing the best available evidence. And this sometimes is a struggle with the home enteral feeding because we don't have really, really good data to share with people, to tell them that this is definitely right for them. And also there's lots of different outcomes of enteral feeding, whether they be health outcomes, social outcomes, practical outcomes, that patients need to think about. The next bit is supported. Patients, when they come into the room, don't necessarily always have the skills to do that complex trade-off exercise that needs to happen. And we, I think, have an active role to play there in helping them do that weighing up exercise. Next is options. Patients should be aware of all of the options that are available to them. And I'm going to touch a bit more on that in a bit. And by following this process, this recognised process, hopefully we move people towards making an informed, preference-based decision. The only word that I think is missing from there is the word values. And I think values is extremely important when making this decision, because home enteral feeding can impact on so many different values for patients. So this was by Glyn Elwyn, and if you're ever interested in learning more about it, he's definitely a good starting point. He's done lots and lots of work. So what I'm going to do is I'm going to pick out some of the key principles that are in the literature around what shared decision-making is, and again, try and map that on to this decision. So even before you get to the point of deliberating about, is this right for me, weighing up the pros and the cons, understanding the information, we need to set the right environment for shared decision-making to happen in. And that comes from both sides of the table. So you've got health professionals. So what we bring to the table is we should have a really good working knowledge of the evidence that's out there. What are patients saying in the qualitative literature? What do any of the other evidence that's out there, as good as it is, what does that say about what enteral feeding is, what the outcomes are, what patients experience as part of that? So we need to then also be prepared to allow patients to make decisions which we might not think are the best for them. So some patients, for their very own good reasons, might want to defer the option to have a feeding tube placed, or might not want to have a tube at all. And we need to be comfortable with that and then support them with that. From the patient's point of view, what they bring to the table, which we have no knowledge of whatsoever, is their own personal lives. What's important to them in life? What are their religious beliefs, their cultural backgrounds, their family lives? What is important to them? And unless you bring that into the decision, there's no way that they can make a values-based decision. So that needs to be part of the decision-making process, and we need to invite it to happen. We also need to empower patients to be involved in the decision-making process. Often before they come into the consulting room or you go and visit them in their homes, there is a power imbalance whether we like it or not, and they feel maybe that the doctor knows best, doctor's going to tell me what to do. And sometimes you need to do a bit of work to level that playing field a little bit, empower them, advise them that they need to get involved, have a questioning style, and we're going to make this decision together. And they often will ask for recommendations, and that's fine. There's no problem in giving a recommendation, but you should try and defer that disclosure, really, to later on in the session. Maybe say, maybe we should understand what's happening here, what's the problem that we've got in front of us, what are the interventions that we're considering. Let's see how you feel about those. And at the end, if they still want a recommendation, by all means, we can give it. But we should allow people first to try and consider how they feel about the information that you're sharing. And that should then set you a good environment for shared decision-making to happen in. So the next stage is understanding the problem. So why are we here talking about this? So for a lot of our patients, the main issue is dysphagia caused by the condition. We need to understand the condition. We need to understand how the conditions cause dysphagia. What are the risks of dysphagia for the patient from maybe their airway point of view or their nutritional status? Is that dysphagia going to get better? Is it going to get worse? And you're setting the scene now for why we maybe need to think about what the options are to manage that problem. And that's where we get onto options. And I mentioned options earlier. So ideally, all options that are available should be presented to a patient. I don't know what you think of. You've seen circumstances where maybe you feel certain options haven't really been made available to patients, or we've taken people down a certain road of a tube placement or not a tube placement. So ideally, all options. So these could be a gastrostomy tube, it could be an NG tube, it could be maybe having a low-profile gastrostomy at some point, it could be deferring the option, or it could be having no tube at all. So making it very explicitly clear that there are options and they have a choice about these options. And I guess it's then our job to try and educate patients, to advise them what those options are, what the outcomes of those options, what are the risks, the benefits. But when you're talking about risks and benefits, it's not just the risks and benefits associated with placing a tube or the surgery involved for that. It's the holistic impact of enteral feeding on patients' lives. We know from the literature that it does have a huge impact on patients' lives. Surely to make an informed decision, people need to have that, be awareness of that before they say yes or no. So it's about making sure we're making people aware of everything that comes with all of those options. Also, when you're trying to talk to people about these things, you do need to assess health literacy very, very quickly, usually. So some people will be able to understand information very easily, some people not so. And you need to make a very quick judgment on how quickly you're going to give the information, whether you need to break it down, what language you use, what tools you use. So hopefully by now, we've got patients who understand the problem, they understand the options in front of them, and we're starting to then get to that trade-off exercise. We're trying to ask people to think about what they feel about the risks and the burden of tube placement and long-term enteral feeding, what they feel about the benefits that might have of starting feeding. And it's a bit like where you go clothes shopping and you're trying on clothes. You're trying to how do they fit? How will I look like this when I go out at night? They're trying on these different interventions. That's what you want them to be thinking. That's what you want them to be imagining, is how would I feel about maybe 4 carers coming into my house 4 times a day to do a bolus feed? How will I feel with this tube sticking out of my stomach? How will I feel that if this treatment might extend a poor quality of life towards the end of life? all those issues will be important to different people. And that's where values comes in. That's the values clarification part of the decision-making process, and probably the most important part of the decision-making process. And that's something that you need to spend some time on. And then finally, we get to making a decision. So patients, as I said at the start, have a few choices that they can make. They can say yes, they can say no, they can defer the option. So I had a patient the other day with MND who was about to go for a tube. I went to do the last check with them that they were still happy for that to happen. And he still felt, I'm doing okay here. I'm at risk of the odd chest infection. But if I go, I'm not going to be able to do my hydrotherapy for a little bit of time. It's going to get in the way of my life. I'm happy to take a risk for the next 3 or 4 months and see how I get on. It probably wasn't the best decision, which I thought for him, but it was based on what was important for him. So we delayed the decision and we supported him with that. So he hopefully made a preference values-based decision. And why is this important? How many people have heard of the Montgomery ruling? Anyone? Hands? Ah, cool, I'm going to tell you something. So the Montgomery ruling is really, really important. It's Nadine Montgomery was a young lady with diabetes, and she was small of stature. She had a vaginal birth, but it ended up with a son who then had complications associated with that and had cerebral palsy. She went to court, she took the obstetrician to court because she felt she wasn't given all the options. She wasn't given the option of caesarean section. She wasn't necessarily discussed the risks of having a vaginal birth with the set of circumstances she was in. And the Supreme Court found in her favour, and it's resulted in a change in the law. So whereas before these situations would have been looked at under the lens of the Bolam test, so if the majority of medical opinion supported the decision that was made, then that was generally seen as okay. But now there's been a change of focus that we should be considering back to the patient. What would the patient attach significance to about the different options available? So this makes it very, very important that we do present all options. So we do present NG feeding, gastrostomy feeding, the different types of tube placement, if they are available to the person in where they're living. We shouldn't decide what options they have or what risks we decide to devolve to the patients. So it is in law now, and I think the next few years, I think people are going to fall foul of this situation. I don't think in home enteral feeding we're ever going to be taken to the Supreme Court, but it's something that you do need to remember and think about. So I just wanted to share a couple of models as well. So there's been a lot of modelling around shared decision making. Gillian Elwyn has done this 3-talk model, which I think is really nice, and it takes you through the different phases that you should see in shared decision making. What I do like about it, and why I think dietitians are perfectly placed to lead in this area, is communication skills are so important to supporting decision making. You know, active listening, hearing what the patient's really caring about, and also being able to communicate really complex information about their condition, about the different tube placements, and also about trying to imagine what it's like at home on enteral feeding. You know, good communication skills are vital to do that. And I think, obviously, it's part of our basic training, and it's something that we work on in all the jobs that we do. So, yeah, I think it's really, really important part of shared decision making. The other model that I think is really good is done by Franz Laguerre, another person who's done a lot of work in this area. And what she recognises is that a lot of the research that's been done in this area looks at the patient, doctor, dyad, just 2 people. And we know that patients don't make decisions just in that isolated environment. So say a patient with MND who's thinking about having a gastrostomy tube placed, they will get talked to by the neurologist, the dietitian, the speech and language therapist, the specialist nurse, their mum, their dad, the internet. So there's all these different sources of information that the patients are getting access to. And as teams, what she recognises is that we need to think carefully about how we approach this. Research done in MND, again, did identify that patients felt clinical teams didn't talk to each other. People were just saying things at ad hoc times and trying to support them to make the decision, but they weren't talking to each other. We didn't know what each other were saying. There may be inconsistent messages. People might have varying knowledge of enteral feeding or enteral feeding tube placements. So I really think this is a really important bit where we can make real progress and we can bring teams together, make sure everyone's got good communication skills, and we all approach it in a really planned way so you have a coherent message. So I think there's opportunities there. Even though I believe that communication that happens between the patient and the health professional is really important to make shared decision-making happening, I don't think it will just happen by itself like that. And, you know, obviously you're only with them for, say, 30 minutes, an hour, and they need more time than that to help make this decision. And there are tools that are out there for other decisions, which we could translate into this decision. So there's something called pre-encounter tools. So pre-encounter tools are things that can either be sent to patients, or you can sometimes have decision coaches who phone patients. This could be a dietetic assistant in your home enteral feeding team who would prepare people to advise them, someone's going to have a conversation with you, but your views are very important. We want you to have a questioning style. We want to try and find out what's most important to you. You could argue that the Penge resource, unintentionally, that having an enteral feeding tube, further questions to ask, is a pre-encounter tool. It advises people, encourages people to question their health professional. It asks them to ask questions which won't necessarily always come up in the pre-gastrostomy placement discussion. The questions that are important to them, practical questions around what it might be like to be at home on enteral feeding. Other things that are out there are decision aids. Everyone heard of decision aids, or has anyone used them in practice at all? No. There's more of them, not in gastrostomy placement, but things like prostate screening, antibiotic care, and they are thought and have been shown with some good evidence to show that they do help shared decision making happening. They improve patients' decision, they improve patients' knowledge. And they basically give people the knowledge, the education they need, helps them weigh up the pros and the cons, it helps check understanding, and it helps clarify patients' values. It does everything that we should see in a shared decision-making process. And this was done by Anne Hogden in Australia. So for people with MND thinking about gastrostomy tube placement. And it's well worth a look, but you could argue that it's not translatable to the UK population. So down in Southampton, Dr. Sally Wheelwright has just started a 3-year study. They're interviewing patients, they're interviewing health professionals, they're doing literature reviews, they're trying to pull out all the information, not just the clinical information, but the practical stuff about what's important to patients about this decision. And they will build that into this decision aid. So hopefully it will have all the information that patients need and all the risks and burdens and benefits that they might need to consider. So look out for that, and that's their Twitter feed if you're interested. And a bit of self-promotion. Has anyone heard of MyTube? Hey. Yes, good. So this is something we produced in Sheffield, again for M&D. A lot of this work has been done in M&D. I don't know why particularly, but this was a resource we produced. It was a series of 25 films. It showed patients in their own homes using enteral feeding, but also we wanted to make sure we encouraged people to think about what was most important to them. And there's a thread of that throughout the website, hopefully, where we encourage people to make decisions based on what's important to them. And we really made sure that they knew they had a choice. So have a look at that if you want. And if we get this right, if we do this better, hopefully people will make better decisions. I really do believe, as well as making the decision-making process more satisfying for patients, if we get it right, we can prepare better for the future with patients. I think home enteral feeding dietitians especially can play a really important role in this, and we're starting to build a really good relationship with them. We're going to be there with them probably, if they say yes, for the rest of their lives. And if we can get that decision-making process right, we can build to hopefully a better time afterwards. And we'll see more quotes like this. So I would argue that the dietitian here has listened to the patient, discussed a very important issue with them, and that's left the person feeling listened to, and hopefully that's been incorporated into the decision they made. So that's my whistle-stop tour of shared decision-making. I've got a minute or so left if anyone wants to ask any questions.